Hello everybody and welcome to the ECIST ED Demand and Capacity Tool webinar. I'm really pleased that we've got two great speakers for this webinar. We've got Chris Green, who's the ECIST Head of Information, and we've got Dr. Dan Boden, who's a very experienced ED consultant, ECIST Clinical Associate, and also a GERFT Emergency Medical Lead for the East of England. So I'm going to hand over to Chris.
Thanks very much, Pete. Hi everyone, I'll just give a brief overview around the tool, why we did it and what it contains. So we created this tool in the emergency care intensive support team to support hospitals to understand their capacity within the emergency department. Now I would say that this is to understand the functional capacity, and by that I mean staff, and not necessarily anything to do with the physical capacity, which is cubicles, beds, trolleys, chairs, etc. The tool is not designed to be any form of performance tool, and it really shouldn't be used as such. And it certainly isn't anything to look at individual productivity of staff. The tool really should be used as an honest reflection of the current practice, and we really can't stress that enough, that the tool should be designed and used so that it reflects what is going on in your organisation at the moment. So why do we need this? Well, the evidence suggests that there's significant variation in the amount of time it takes to see a clinician by time of day, day of week. We've used this tool in multiple organisations around the country over the past 12 to 18 months, and what we can see by the graph in the bottom is that we've got each day of the week, and the line illustrates the amount of minutes it takes to be seen by a senior clinical decision maker. So if a patient arrives, say let's say around 8 o'clock in the morning, all the way going through to about 2, 3 in the afternoon, these patients are seen relatively quickly within 30, 40, 50, going up to 60 minutes. But we can see as the day progresses, that time extends significantly, with patients who come in after 11 o'clock at night and taking a substantial amount of time to be seen. So Dan, I just wondered if you had any clinical context around this.
Yeah, thanks, Chris. I think it's a really important point to make that for me, as clinicians, we want to give the best quality care that we can, and the variation from day to day and week to week is quite frightening, and I don't think it's right that a patient should arrive at 8 in the morning and get potentially a different quality of care from arriving at 2 in the afternoon or 10 at night or 2 in the morning. And so to flatten out that time to be seen over a day by day and a week by week basis is really important. And that distribution of time to be seen is mirrored across the country. And when I saw this tool that you'd done, it just seems to me to be really important that as EDs across the country, we look to minimise that variation. Great, thanks Dan.
And something this tool can be also used for is to actually then have a look at about patient safety and quality. As part of this tool, we also offer additional data diagnostic analysis. And as part of that, we have a look at what the impact of patient safety and outcomes is for patients who have an elongated stay in ED. It's something which we talk about a lot, and something which there's multiple evidence and papers have written about. So this is what the tool looks like. This is the functional tab on the actual model, and we'll make this tool available to everybody. So what we can see is that the graph on the top right hand side illustrates by hour of the day, and you'll see that each hour of the day has 7 bars, and they reflect each day of the week. In short, this graph shows that if the number of patients is below the line, this represents a gap in the amount of staff that we have in order to treat the patients. However, if the bar is above the line, as we can see from midnight through to 8 AM, we can see the bar above the line. This reflects that we do have enough staff in order to see our patients. If we don't want to see this in a graphical format, we can also see it in a numerical table down in the bottom left-hand corner. You'll also notice 2 other aspects on this slide. One is the demand percentile, and this will be to have a look at the amount of attendances that come through our front door by time of day, day of week. And we'll come on to have a look at that in a couple of minutes' time. The other table down here reflects the amount of staff and the patients per hour that each of those staff can see. Now, as I mentioned in the introduction tab, we don't want to have a look at each individual member of staff. So we're not saying that Chris can see so many patients per hour, Dan can see so many patients per hour. What we're looking at is staff groups. So we'll be saying how many patients can do our consultancy, how many staff, how many patients do our middle grades, SHOs, etc., etc. Something that we've certainly seen as we've been doing this around the country is that although every trust in the country has consultants, middle grades, SHOs, etc., etc., these sometimes might be called different things. So what you can do in this column here is just type in the staff type name and it will automatically feed through to the rota tab. So when we have a look at the attendances, it's something to really, really bear in mind is that we want to have a look at a significant amount of data. There's no point just having a look at one day in particular or 1 week in particular. The tool will work off a historical level of demand. And the time frame that we suggest for this is between 6 and 12 months. But then we also want to have a look at the variation in attendances by time of day and by day of week. So what you can see for this typical trust is that sometimes they have seen 220 patients coming through the front door, and sometimes they've seen upwards of 340, 350. Now, if we worked off the average, 50% of the time would be right and 50% of the time would be wrong. So what you can do in the model is you can look at various different levels of demand so that you can say, well, if we were on an averagely busy day, say the 80th centile, we would see 320 patients per day. If we were at the median or the 50th centile, we're around the 280 attendances per day. The demand percentile is a variable, and you can just play with this in the model. You can be in a business meeting, potentially writing a business case, and you can have a look at the various different levels of demand. What you can also do is you can also future-proof this. So, for example, although our average attendances might be 280, 290, what if in 12 or 18 months' time, our maximum level of attendances now, 340, becomes our new average? So that you can just easily type into the demand percentile 100, and it would update the model there and then. So Dan, what do you think about the demand attendances? I know that it's something that's been significantly increasing over the past few weeks. Yeah,
I think that the future proofing is really important, a really interesting piece of work where a lot of trusts have now bought into the tool, and not physically bought and not paid for it, because Chris, you'd have been multi-millionaire by now, Chris, if you'd have paid for it. But they've really they've really engaged in the tool, and but there's some trusts now who are thinking about doing a sort of second iteration. They found that their demand profile has gone up, unsurprisingly, and it'll be really interesting to see where we are in 6 and 12 months with these trusts and how the tool adapts. For me, the graph is really helpful about not going for the mean. If we're staffing our departments to the mean, 50% of our days we're not going to meet the demand. And so, but whether that figure you choose the 75 or 80 or 85th centile is down to, I guess, individual local discussions. And some of the trusts I've worked with have been encouraging 85th centile data, and that seems to have worked quite well. But again, that's kind of open to discussion. But yeah, no, really important to get the demand right and to think about future proofing.
Great, thanks, Dan. And that's why in the functional tab of the model, it's actually a variable. So you can just kind of bounce ideas around. You could just play about with, well, let's have a look at the 70th, 80th, 85th centile and settle on one that you feel. So the next level to look at is the productivity. Now, some will consider this to be the most contentious aspect of this. So what the model allows you to do is it allows you to enter any staff type that you might have. So as I said earlier, you might have consultants, middle grades, SHOs, but you might also have juniors, you might also have different tiers of doctors, you might also have nurses. One thing to stress around this model is that it is designed for senior clinical decision makers. That's not meant to be a derogatory term. We really value the input and the work that porters, nurses, registered nurses, healthcare assistants have. However, this model is for clinicians that can make clinical plans for patients. The reason why we need this is that we're not saying that every member of staff can see the same number of patients per hour. We know that there's guidance from the Royal College of Emergency Medicine and the Royal College of Nursing on this. I know, Dan, you'll be talking about this just shortly. But what we also want to be able to do is, as I said right at the beginning of this presentation, is that it needs to be an honest reflection of what is going on in the organisation. So, Dan, what do you think about the different patients per hour and the productivity of each of the staff types?
Yeah, I guess my bulk of my consultant career was at Derby, and I did a kind of workforce plan in 2015, 2016, and to do that effectively, I looked probably a bit early actually, and looked at our productivity data, and I was very surprised at what I came up with and what our IT system was showing as the productivity of different clinicians with different cohorts of clinicians. And probably 5, maybe 7 or 8 years ago, RChem would have said 2 or 3 patients per hour. But that's changed massively, and it's changed massively because the quicker and easier patients maybe are being streamed to co-located GP or managed in minor injuries units or treated in clinical areas away from the main body of the emergency department, which is right. And it's right that the ED is for the most, traditionally the most unwell patient groups. And I remember as a registrar, an associate specialist where I worked in one particular trust in the West Midlands who'd see 70 patients a day, and they were minor injury and very, very minor illness. And those days in EDs have gone forever. And acuity is higher, and dependency is higher, and frailty and complexity, and all those different factors are kind of within a formula are the work of the emergency department. And so when I got our benchmark data, we were coming out as roughly 1 patient an hour for middle grades and for SHOs, a little bit higher for the EMPs who were seeing more minor illness, about the same for AMPs. And I then was quite concerned about our data, and so I benchmarked it, and I probably had 20 or maybe 30 trusts have given me their data on numbers of patients per hour, and the variability is actually fairly minimal. And we're now nationally looking at, on average, one patient per hour for the cohorts of clinicians who are seeing individual patients from start to finish. But that includes seeing the patients from scratch, taking the history, examining, writing them up, collating the investigations, and dealing with all the kind of complexity and acuity I've talked about. And what I would say is the consultant, you look at that and think, crikey, that's 0 patients per hour. How I've done that at Lincoln, I've used this model, is I've put, for the EPIC, for the emergency physician in charge, as we call it, or other trusts might call it differently, they really should be doing that helicopter overview and managing their ED without seeing patients during that shift. But you may well have a consultant working in the pit stop or the rapid assessment area who might see half a patient an hour or a bit more. You might have shop floor consultants who some are seeing 1.5 or even 2 patients an hour. And at Lincoln, we've done that. We have 3 different consultant shifts, and we're able to change the productivity to account for different consultant shifts. It might be have a middle grade shift in minors when they can see a couple of patients an hour. And the most effective way for me, I think, for EDs to use the tool is if they can, and their IT system allows, is to actually use their own productivity data. But please feel free to make contact. My email's at the end, and if you want to kind of sense check your own productivity data, then please feel free to, and I'm happy to then share the national data we've got to check you're in a ballpark figure.
Yeah, I think that's a really important point, Dan, is that there's definitely 2 ways in which to look at this productivity. There's the kind of the easy way or the hard way. The easy way is to work off anecdote or to work off some fantastic evidence that you've now got down, which I think would be absolutely fantastic for people. The harder way is to have a look at their patient administration system and to work out who sees what, when, why, where, etc., etc. I suppose the challenge from a informatics point of view is that not all of the staff types record their name under when they saw the patient. They might just always have it under a certain type of person, or whoever's got their smart card in the machine, for example. So, I think there's that balancing line. But as I said before a couple of times during this presentation, it needs to be a realistic representation of what's going on in the individual department.
Yeah, and Chris, sorry to butt in one more thing on that. I think you made this point at the beginning. It's really important not to be punitive with the productivity. So in the past, what I've done is I've looked at I've anonymized the productivity of different cohorts, of different clinicians within a particular cohort, so advanced practitioners or EMPs or middle grades. And I kind of knew what they were going to be seeing roughly per hour, but it was enlightening for them in an anonymized way to see the numbers of patients they're seeing compared to their peers. Really to look particularly at the extremes, because there might be something about someone's individual practice who's seeing 0.3 or 0.4 patients an hour where you think, are you doing, is there anything you could do differently? But if a clinician is seeing 4 or 5 or 2 or 3 patients an hour, you'd also be concerned about the quality of care at the other end as well. And
absolutely,
what I've found is clinicians who are seeing on the lower end tend to get, amazingly, they tend to get load more compliments from patients and from staff, and how we get that balance right of quality of care against productivity is really sensitive and really important. And as I say, really happy to share the work I've done on that.
Thanks, Dan. So the third variable in the model, so the first one is the demand, the second one is the productivity, the third one is the actual amount of staff that we have on at any one point. So the rota works on 3 different ways, and we'll pick up on that in a few minutes' time. What the model does not take into account is that it doesn't take into account breaks. The reason why it doesn't do that is because it's not as though you can just say, right, well, I'm just going to stop doing what I'm doing, I'm going to go and take my lunch because that's the time I always have my lunch. So you have to take into account the pressures that the department are being under. And equally, if a staff member is working but they're not clinical, do not include them. So as Dan was saying, if a member of staff is the emergency physician in charge, don't include them in this particular model. And I've seen kind of 2 ways in which to kind of handle that. One, you can kind of just take them out entirely, or you might kind of say, well, actually, when our consultants work, all of our consultants don't see any members, any patients. So the way in which to do that is that if you want to include them on the rotas, but you don't want to actually feed them through, just put the consultants down as the productivity of being 0. But what you can actually do in this model is that there are 3 different rota tabs. And the reason for that is that I was working with an organisation up in the Northwest, and what they were saying to me was that they had a rota that they were working to, but for whatever reason they couldn't fulfil it, either through vacancy rates or sickness rates. And so they were actually working off a skeleton rota. But what they said to me was, Chris, actually, could we put in what we currently work off, what we want to work off, but then ideally, if we made such significant changes, what would be the potential impact going forward for the next 12 months and 18 months? And that's exactly what you can do through the model. So actually, if we did make any changes to the productivity through different ways in which we want to work, or if we were able to have more staff, what you could do is feed that through onto the rota tabs. And then what you can see over here on the 2 graphs is that we've got my current working in the blue line, and then this line being the amount of additional staff that we can see. I also worked with an organisation who wanted to kind of have a look at the amount of substantive staff against the amount of locum staff they had. It was really, really important because what they were being challenged by is the amount of additional expense that they were being caused by the use of locums. However, using this tool, we were able to help support them through that evidence and say, actually, if we only used our substantive staff, we would be under a significant amount of pressures. So the main 2 reasons for doing this is either through additional questions such as that, or providing business cases to increase our staffing vacancies. Dan, what do you think about the changing the rotas and the ability to do that through the model?
It's incredibly helpful to be able to, and I think it takes some time. It's really important that you get the current rota right and spend some time almost cross-checking every cohort clinician to make sure you've got the current rota right. But once you've done that, the ability of the model to adjust to any proposed rota and a future model is is so quick and easy to do just by literally adapting changing a given shift or adding in one more clinician. You can see a stepwise change in how your rota is going to match demand, and that it's just really, I just find it really, really visual and really easy to use.
Thanks, Dan. So that's the end of the talk from both Dan and myself. You'll see on the screen both Dan and my email addresses. Please feel free to contact us if you have any questions or if you'd like to access the model, and we'll make these slides and the tool available online shortly.
Okay, Chris and Dan, that was a really, really great talk, and everybody can see your contact details are here, so if they've got any questions. But I've just to finish it off, just got a couple of questions. So I guess the first question is to you, Dan. Just really succinctly, there'll be some people thinking, where do I start with this? Where's the best place for people to start, if they want to do this, undertake a demand and capacity exercise in 3D?
Yeah, thanks. I think for workforce, really brief, there's three different kind of key elements. One's getting your recruitment right. One is getting the retention right and really making sure that you're able to keep your staff and value your staff. And the third is the capacity and demand work. And for me, the capacity and demand work should be done first. It's really important that we model what we need to be providing to give high quality patient care. And it's such a simple and easy tool to use that I'd really urge everyone to do that piece of work first. What I've done at Lincoln, for example, is I've modelled Chris's work, and then for a week we've just trialled that rota. And what we found is we've, having trialled that rota for a week, we had a tough Monday, as I say, really high attendances on that first Monday. But once it's settled, we're able to show some really powerful evidence on the benefits of getting our staffing right, both for patients. So we're seeing patients earlier, we're patients who can go home and be discharged effectively can be discharged earlier and reduce crowding within the emergency department. Much better for staff. Staff were more engaged and felt that the role of an emergency medicine physician was much more enjoyable and really felt they really enjoyed that week because they're able to give a better quality of care. Getting that right and getting that rota right then helps to evidence your workforce plan, and very happy to support any individual trust with kind of calculations you need to convert what's an effective rota into a genuine workforce plan at that given point in time. And then really important that it's then future proofed to meet future demand moving forward. And again, I'm happy to share some work that's been done by other trusts in that area. Do that first, use Chris's tool, and then we can absolutely support with recruitment of staff and retention of staff and getting the education, the training and everything else right to keep staff. But this for me is absolutely vital piece of work for every ED in the country, really.
Brilliant. Thanks, Dan. And then final question to you, Chris. This tool, along with many other tools you've created have been your brainchild. So I'm sure some people listening in will think, well, where can I get a hold of the tool? So what's your advice?
Yeah, no problem. I think that's a really valid point, actually, Pete. And we want to make it much more accessible to people. So they can either contact myself or Dan. Our email addresses are up there. They can also contact yourself, Pete. But we're going to also put the tool on the NHS Fab Stuff website. Also put it on the NHS England website. And people can either contact us through that website, through our emails, or through the Emergency Care Intensive Support Team website.
Brilliant. Okay. Well, thank you, Dan and Chris, for a brilliant webinar. Okay. Thank you.